Hello and welcome to this video comparing the emerging field of AI-guided medical decisions and those made by trained medical professionals. Recently, claims were made that a new AI could better detect breast cancer when compared to a radiologist. This was less of an AI and more of a decision system that was incapable of self-directed function. It also highlighted one of the major flaws in both the common understanding of a medical AI and what they do. For this video, we are going to use decision support system, AI, and program interchangeably with program AI and system, but there are differences that will be fleshed out in another video that are important to get a full grasp of this concept. Unlike the flesh and blood medical professionals, these systems are a program. There is no self-awareness or direction. This leads to a cause and effect relationship that is predictable and obvious. It also means no judgment calls or discretion. An AI-like program gives a result based on a percentage, often arbitrary threshold, and similar quantifiable variable. A doctor can use their experience and knowledge to identify what might be a solid mass in one person, but a benign solid mass of fat in another. The need for these programs that support medical care is necessary because there is a finite number of doctors and specialists. They need years to train and more years to specialize. This leads to a far greater demand than supply. A program or AI that can do the same job repeatedly, without stop and with more consistency, is a boon the overburdened medical field needs. This sounds great, except the same programs and AIs might well open up the services to liabilities they have never seen before. As said, there is a general shortage of doctors in many fields for a variety of reasons. Oncology is notorious for its high attrition due to stress, depression, and a generally thankless task. To choose the right medicine, dose, and timing, the patient's history, response, general pharmacology, general health, and more need a discerning mind, and it is needed regularly. Without enough oncologists, that becomes a buyer's market, and so it gets harder to be treated well, and those in a public system have to provide care to so many they become overburdened. If parts of this, like the dosing regime for chemotherapy, could be outsourced, a patient could be given better care. This is where AI and similar medical programs come in. In practice, it is not so simple. An effective program is like YouTube's algorithm, but in theory it actually works. It relies on a lot of data, a demonstrated or identifiable pattern, a viable way to implement the results, and a well-established knowledge of the medical field that it is being used within. An already complex scenario made all the more complex by the introduction of yet another variable. Let's use an example of how one of these systems could work. A patient presents with a sore throat, malaise, and fever. This could be anything at this stage, and a medical decision system would follow that. Think of Google's answer to any list of symptoms you present, and how it is always cancer. A more advanced system could either have more symptoms entered, or be able to adapt as the disease progresses. If a runny nose develops, then you might think influenza or cold. What if there were large splotchy rashes or white spots? The obvious candidate is now measles. A machine would need to start with one of these symptoms and exclude conditions based on the presence or absence. Then it would take this list and apply the second symptom and repeat the reduction in list size. This will continue until symptoms run out or a final diagnosis is reached. This, of course, assumes that the symptoms are accurate, appropriate presentation is made, the program can understand input and not put out a garbage answer. By contrast to this, a doctor is able to work with many limitations and barriers. A doctor is there and able to see the symptoms, both those that are stated and those that are unstated. They can further question if a pain is sharp, stabbing, intermittent, and more that goes beyond the single qualifier of "it hurts." A doctor can tell the difference between a patient presenting with genuine pain and one that is exhibiting drug-seeking behavior. Based on these questions and diagnostic tests, a doctor can possibly identify and provide a diagnosis. Where they cannot do so, there are ways to extend the information available or manage the symptoms until a more definitive result is achieved, something that would be outside the scope of a program's ability to execute. This in of itself could be extremely useful in training new staff. A new doctor or student might be able to take a patient going through the symptoms and reaching a diagnosis. The decision system then examines the same data and the two can be compared. The process of reaching the diagnosis can be compared and errors identified in either the student's reasoning or the system itself. This is the big problem with a program. The decision support systems and quasi-AIs rely on probability determination, an arbitrary threshold that is set and decided based on the available information. Think back on the first example and the three symptoms given. An AI might just accept that that is enough information and give a diagnosis, only for it to be proven wrong later. Alternatively, the symptoms as reported may not match the terms the program uses, and it could either not find a diagnosis or give a completely inappropriate and wrong result. This is obvious in the case of the recent breast cancer analysis AI that gave a percentage probability with greater accuracy than the radiologists. The problem radiologists don't get the option of saying the image has X percentage of cancer being there. They need to give a definitive answer, one way or the other. This will change over time, but for now it is simply the way things are. This is a problem in single diagnosis processes like radiology. In acute care like emergency rooms or chronic care for cardiology, this could be less of a problem. A program which monitors your blood pressure and blood biochemistry could allow a system to alert staff to an impending heart attack or another acute issue, an important achievement in the overburdened and understaffed wards. Over a period of weeks or months in the ward, a patient could produce enough data that a system could predict these events with surprising, if not uncanny accuracy. A doctor cannot do this, as it requires a continued presence. They have other patients, other tasks, and other duties, which prevent them from providing a constant level of oversight to their patients. as with other learning algorithms, there is another problem with the data. Some biases exist. A simple example is the efficacy of certain hypertension medications in different racial groups. They have widely varying effects, and this leads to a program learning that some drugs do not work for certain people. Where race is not known or measured, it may suggest that the wrong drugs are prescribed. This leads to a system of either ineffective or less effective care as a result of taking the wrong sample and trying to extrapolate terms beyond the scope of what they can be used for. These arguments cover each side of the main driving force between AI and medical experts. Each side of the coin is part of the other. The limited staff for healthcare and the early issues of a very premature technology. There is another issue with this. These systems are largely ad hoc or proprietary at present. This means there is either a lack of transparency or a lack of verification. What we do have for solid established procedures are found in more established and empirical formats. Something like PubMed, which includes BLAST for genomic predictions and is derived from laboratory data. Nationalized electronic health records, which give an idea of population health and public health initiatives. Then you have global epidemiology, which tracks patterns at a macro level, but nothing which can be taken down to an individual and applied consistently and effectively. This also raises a question of who is liable when something goes wrong. Did the programmer who was making the project become accountable when they failed to add a particular variable or missed a column in a dataset? Was it the doctor who used it at too early a stage? What about the health service that put this experimental program into practice? Each person or entity adds more complexity and confusion to an already uncertain legal question. In a litigation-ready country like America, this might be a recipe for disaster. Overall, this is an inevitable development in healthcare. The current teething issues of an early technology are a problem. Both the law and staff will need to adapt to this new reality, and slowly but surely, services will need to recognize this fact, as both limitations on staff and a greater demand on their time occur. This technology could be powerful, could be effective, but we are not there yet. Thank you for watching this video. If you found it interesting, consider liking, sharing, and subscribing. Please post any comments, questions, or suggestions below.